This video I am going to discuss about the emphysema. Emphysema is abnormal, permanent, irreversible enlargement of the air spaces distal to the terminal bronchioles along with the destruction of their walls, and it takes place without obvious fibrosis. So what emphysema will do? Emphysema will cause the dilatation of the air spaces. This dilatation is due to the destruction of the alveolar wall, which leads to the collapse of the alveoli during the expiration, and ultimately it will result in the obstruction of the airway spaces. So it's a part of the obstructive lung disease. Why the alveoli collapse during the expiration? Whenever there is a destruction of the elastic tissue in the lung parenchyma, the alveoli will collapse because the small alveoli or the small airway spaces held open by the elastic recoil of the lung parenchyma. Here is the chest X-ray showing the posterior interior view as well as the lateral chest view. In the posterior interior view, you can appreciate the hyperinflated lungs as well as the depressed diaphragm and hypovascularity of the lung parenchyma. In the lateral view, you can appreciate the increased diameter, increased interior posterior diameter, and increase in the retrosternal space. Here is the lateral view again, showing the increased interior posterior diameter, increased retrosternal space, and the flattened diaphragm. What are the types of emphysema? There are 4 types of emphysema: the Panacinar or the proximal acinar emphysema, the Panacinar, paraseptal or distal acinar emphysema, mixed and unclassified or irregular emphysema. So here is the picture of the normal acinus showing the intact alveolar walls, intact lung tissue, intact alveoli. So here is the picture of the centriacinar emphysema or the Panacinar emphysema. In the centriacinar emphysema, you can see that only the proximal acinus are involved. But in the Panacinar emphysema, you can see the distal acinus as well as the proximal acinus both are involved. So here is the picture again of the 4 types of emphysema. The centrilobular. The centrilobular, you can see the proximal acinus are involved. The panlobular, the distal as well as the proximal both are involved, and the paraseptal, the distal, only the distal ones are involved, because the paraseptal, as the name suggests, it takes place along with the lobular subtarsal connective tissue in the lung tissue where the fibrosis has been taken place, where the atelectasis has been taken place. Or irregular emphysema, irregularly involved acinar, means it can involve the distal, it can involve the central, it can involve the proximal. It takes place in a irregular form. So here is the description of the centriacinar or centrilobular or the proximal acinar emphysema. In this, the dilatation of respiratory bronchiole take place. Upper lobes and the apical segments are more commonly involved. It can coexist with the chronic bronchitis. The patient having the chronic bronchitis has increased risk of developing the centriacinar, the centrilobular or the proximal acinar emphysema. It also takes place in the smoker and the coal mine workers. Here is a picture of the centriacinar emphysema. If I talk about the Panacinar emphysema, the whole of the acinus are uniformly affected. Lower lobes are the more commonly involved. It has great association with the alpha-1 antitrypsin deficiency as well as the cigarette smoking. Here is the picture of the Panacinar emphysema. And if I talk about the paraseptal emphysema or the distal acinar emphysema, the paraseptal, as the name suggests, is take place along with the lobular connective tissues, along with the septas, along with the pleura, the peripheral part of acinus, as well as it take place in distal portions, or it will involve the distal acinus. Irregular emphysema, it's another commonest type of emphysema, but the most commonest type is the proximal acinar emphysema, but it has least significance. It is common around the scar tissues, or it's a combination of the different of other types of emphysema. Here is a mixed acinar emphysema. So you can see the mixture of the centri-acinar or the paraseptal. This one is this destruction of the alveolar wall is taking place along with the septa, so it is the paraseptal emphysema, and the central one, there is a destruction of the alveoli or the enlargement of the air spaces in the center, so this is the centri-acinar emphysema. So mixed form or the irregular emphysema is a combination of the both types. So here is the pathology of emphysema. First of all, tobacco smoking is the major risk factor for the development of the emphysema. As the person smoke for the long period of time, alveolar cells and the macrophage cells start secreting cytokines, interleukin 8, leukotriene B4, and the TNF, tumor necrosis factor. They have greatest role in development of the emphysema because it will give the chemotactic stimulus, which result in the reflux of the neutrophils. It will develop the pro-inflammatory state, as well as it will release the growth factor, which result in the structural changes. Another thing happened in the emphysema, there is an imbalance between the proteinase and the antiproteinase. There is a development of the oxidative stress state, development of the reactive oxygen species, free radicals, which ultimately result in the destruction of the tissues. Alpha-1 antitrypsin has got the major significance. How? Whenever there is an inflammatory state, there will be a reflux of the neutrophils. Neutrophil will release the elastase, which is a proteinase, and whenever there is a release of elastase, or we can say the proteinase, it will result in the digestion of the elastic tissues of the lung. And whenever there is a digestion of the elastic tissue in the lung, it result in the collapse of the alveoli, and collapse of the alveoli ultimately result in the obstruction of the airway spaces and development of the hypoxia. But what this alpha-1 antitrypsin do? This alpha-1 antitrypsin inhibit the elastase. So ultimately it is protecting the lung tissue from the digestion. So here is the pathophysiology again. Whenever there is a, as I told you, whenever there is a destruction of the elastic tissue, loss of elastic recoil of the lung, there will be a expiratory narrowing of the airway spaces as resulting in the airflow obstruction. Whenever there is a destruction of the alveolar septa, destruction of the alveolar septa result in the reduction of the surface area for the gaseous exchange, and it will result in the hypoxia. Patient will present with the dyspnea, cough with or without expectoration, wheezing, loss of weight, peptic ulcer, hypercapnia, increased concentration of the carbon dioxide in the arterial blood, which result in the changes in the central nervous system, as well as the barrel-shaped chest. So here is the picture of the barrel-shaped chest. Before ending this video, I am going to discuss about the morphology in the emphysema. Emphysema produces a voluminous lung that is overlapping the heart and hiding it from the interior chest wall. Generally, the upper two-thirds of the lung is more severely affected. In the irregular emphysema, which is secondary to the scarring, we can see the large apical bulbs or the bullae, and microscopically we will see the alveoli are there is abnormally large alveoli that is separated by the thin septa, and there is a focal centri acinar fibrosis. There is a loss of attachment to the outer wall of the small airways. Prolonged vasoconstriction take place and it will result in the pulmonary arterial hypertension. So the emphysematous patients are known as the pink puffers. There will be a development of the cor pulmonale and the congestive heart failure. Cor pulmonale and the congestive heart failure develop secondary to the pulmonary hypertension because of the prolonged vasoconstriction, and the patient death is usually take place due to the coronary artery disease, respiratory failure, right-sided heart failure, massive collapse of the lung. And the treatment, if I talk about the treatment options include smoking cessation, oxygen therapy, long-acting bronchodilators with inhaled corticosteroids, physical therapy, alpha-1 antitrypsin replacement therapy. So here is the picture showing the difference between the chronic bronchitis and the emphysema. The chronic bronchitis clinical diagnosis based on the daily productive cough for the 3 months or more in at least 2 consecutive years. And the emphysema depends upon pathological diagnosis like permanent enlargement and the destruction of the air spaces distal to the terminal bronchiole. Chronic bronchitis patient will be overweight and cyanotic. There will be elevated hemoglobin. There will be peripheral edema and the rhonchi and the wheezing. But in the emphysematous patient, severe dyspnea, quiet chest, X-ray will be showing hyperinflation and the flattened diaphragm and hypovascularity of the lung tissues, and emphysematous patient will be older and thin. So here is the picture showing